Milestones in Medicine is sponsored by the Methodist Hospital Foundation, Houston, Texas.
Welcome back to the continuation of our special Milestones in Medicine series on new developments in the battle against coronary atherosclerosis. In our earlier programs, we heard several prominent investigators emphasize the role of cholesterol in the pathogenesis of coronary artery disease. Although a link between blood cholesterol levels and atherosclerosis has been suspected for many years, little confirmatory evidence has been available. However, results of a study published in a June 1987 issue of the Journal of the American Medical Association provide some strong evidence that it may be possible not only to reduce the progression of atherosclerosis, but to actually decrease the severity of existing lesions in some cases by means of an aggressive cholesterol-lowering regimen. This study, the Cholesterol-Lowering Atherosclerosis Study, or CLASS, was conducted by Dr. David Blankenhorn and his associates at the University of California School of Medicine. CLASS was a randomized, placebo-controlled angiographic trial designed to determine whether cholesterol-lowering measures would alter the course of atherosclerosis. The study population consisted of 162 non-smoking men with previous coronary artery bypass surgery who were divided into two groups. One group was treated with combined cholesterol hydrochloride and niacin, and aggressive diet intervention, while a placebo group followed a less stringent diet. After 2 years, the drug therapy group showed large, statistically significant decreases in total cholesterol, triglyceride, and LDL cholesterol levels, and a concomitant elevation of the HDL cholesterol level. In contrast, changes in cholesterol levels for the placebo group were considerably less. Possibly the most important and certainly the most intriguing finding was that these changes in cholesterol levels were associated with angiographic evidence that progression of disease was significantly reduced in the drug-treated group compared to the placebo group. Furthermore, angiography showed actual regression of atherosclerosis in 16.2% of patients treated with drugs, compared to only 2.4% of the patients who received placebos. Today's program will focus on the cholesterol-lowering atherosclerosis study and the clinical implications of its results. Joining Drs. Vincent Friedewald and Antonio Gatto at the Methodist Hospital in Houston are Drs. Thomas Ryan and William Roberts. Dr. Ryan is Chief of Cardiology at the University Hospital and Professor of Medicine at the Boston University School of Medicine. Dr. Roberts is Chief of the Pathology Branch of the National Institutes of Health.
Dr. Ryan, does CLASS prove that atherosclerosis is reversible? And is that study consistent with, or is it at variance with any other similar studies?
Well, without being too technical, I would have to say right at the outset, I don't think that CLASS proves that atherosclerosis is reversible. I think it presents some very compelling data that suggests that there's pretty good evidence that coronary vascular diameter, as assessed angiographically, changes in a population of non-smoking, normotensive men with angiographically proven coronary disease over time if you substantially lower blood cholesterol or its components, increasing HDL. Now, as a clinician, I might well infer that that's reversing atherosclerosis, but by no means is angiography measuring size of plaque, as I'm sure Dr. Roberts would be quick to remind me. But I think to the degree that we can take faith in an angiogram that shows a very high-grade obstructing lesion, and I think that the technology of angiography is very widely extant that says that can be done with considerable accuracy. To take a high-grade lesion and see it regress to an insignificant lesion is something we're seeing not in the context of cholesterol lowering so much, but in angiography done during the acute stages of myocardial infarction. We've come to appreciate that thrombus formation or thrombolysis occurs over time, and an angiogram at 90 minutes after thrombolytic therapy might show a residual lesion that we'd call 80%. You go back 6 days later, do an angiogram, and that 80% lesion will be a 40% lesion. There's some very recent data out on that in the TAMI trial, but that's an aside. I think angiographically we are seeing what we're quoting, or quotes as regression of disease. The class study has some very interesting and provocative data along that line in chronic stable angina.
Dr. Roberts, a key part of this study is what they term the global change score in assessing the progress of the atherosclerotic lesions by using angiography. Now, I know that you've been concerned, you pointed out in the past, with reasons for inaccuracies in using angiograms in assessing the true state of the degree of coronary atherosclerosis. For that reason, do you have any reservations about this study?
Well, I think one has to be careful, but despite the fact that there are some limitations to angiography, just like there are limitations to most studies, certainly it provides the best available information during life regarding the status of the coronary arteries. I think it's worth keeping in mind, however, that if one is looking at a coronary artery, and let's just make this the coronary artery and this the internal elastic membrane, the media would be on this side of it, and this would be the external elastic membrane. Well, here would be an atherosclerotic plaque as it might be viewed by angiogram. Here the blood would be coming through here. Now that is read by measuring this diameter here versus the diameter of the artery proximal or distal to it. And therefore, since this diameter is much less than that, obviously this is a narrowing. Now that implies that the rest of this is clean, is free of disease, but in actuality, in a person with symptomatic coronary disease, the chances of finding an area in the coronary artery that contains a significant narrowing, in my view, is only about 5%. So this is the unreal world. This is not the real world. The real world is that there's also plaque here, and there's also plaque here. It's just not as narrow as it is here. So this diameter here is read as being normal. This is the true lumen. This lumen is about half of that, so this is a 50% narrowing. The problem is, by angiogram, one does not get to see the internal elastic membrane. This is a luminogram. On the other hand, one can have a coronary artery with a central lumen like this be filled with plaque, and that diameter from here to here can be almost normal. So one can sometimes have considerable narrowing and it not show up so severely by angiogram during life. But nevertheless, it's a great technique and the best thing we have during life. I think the measurements that they use in this study are very fancy, with computer measuring the edges of the lumen and so on. So it's a little better than the usual reading of diameter reduction.
Well, let me ask you to speculate a little bit further, and we'll all accept that it's speculation. From the pathologist standpoint, if we accept that such reduction has occurred, what part of this complex lesion we call an atheroma is the part that's shrinking?
Yeah. Well, I think that the information from human beings, at least morphologic information on regression, is virtually nil. I think we have to keep in mind that one can do an autopsy only once. So it's not possible to compare a morphologic examination on one occasion to a morphologic examination on another, whereas you can do an angiogram multiple times. There's no question experimentally that the lipid component of the plaque is reversible, whether the lipid be intracellular or extracellular. And the best study, and one of the first really, as far as I can see, is a study by Armstrong and Warner and Connor back in 1970 on the monkeys. And they put these monkeys on a high atherogenic diet for about 16 or 17 months. And then various groups, and they sacrificed some at 17 months and showed a great deal of atherosclerosis. Then they put some groups on a very low cholesterol, low fat diet and sacrificed them at 60 months and showed that the atherosclerotic plaques, which had been present at 17 months, had virtually disappeared at 60 months. So there's no question experimentally it's reversible. Bob Whistler and his group in Chicago have shown that not only is the lipid component reversible, but they believe that some of the collagen component is also reversible. There's multiple types of collagen, and some of the early collagen they think is also reversible. So this is a very encouraging sign, and I would predict that if the 1970s are going to be the era of blood pressure lowering, in the 1980s the era of cholesterol lowering, that the 90s are going to be the era of reversibility emphasis.
Dr. Ryan, one of the ways they achieved this reduction was with the diet. I'd like for you to comment on that diet as a clinical cardiologist, a diet that consisted of 125 milligrams of cholesterol, 22% fat, 10% polyunsaturated fat, and 5% saturated fat. Is that a sort of diet you would give your patients?
Well, that's a mighty stringent diet, and it's, I think, to the credit of the investigators that they put their control population on a cholesterol fat-restricted diet, took as their control the American Heart Association Phase 2 diet, which has about a 30% of the calories coming from fat. This is down to 22%. 10% polyunsaturated is about the same, but the 125 milligrams of cholesterol is quite stringent. In their placebo group, or the control group, they had an 8% reduction in cholesterol. I think it was the impact of this stringent diet plus combined therapy with cholesterol that produced very substantial reductions in cholesterol that I think this study, at least in my view, underscores. And it's in keeping with some of the other data that's beginning to emerge, that in ileal bypass studies where you really reduce blood cholesterol as much as 40%, there's some objective evidence angiographically of regression or reversibility of lesions. But I would expect Dr. Gatto could say a little bit more about the actual composition of this diet.
Well, I don't have much to add to that point. It's a very rigid diet. I think the control group was on a slightly less rigid diet than the treatment group in the class study, but that's a relatively minor point. Most patients are not able to adhere to this rigid a diet, in my experience. The group in which Blankenhorn demonstrated regression, bear in mind, were following not only this rigid a diet, they were also taking 29.5 grams of cholesterol and 4.5 grams of nicotinic acid daily. And that is a very tough regimen for anyone to follow. I would say that the main limitation in trying to extrapolate this to the general or average individual with atherosclerosis and coronary disease is that this degree of adherence to diet and that particular medical regimen is difficult to achieve.
I think it's important in study design to recognize that pre-randomization, they built this into their study design to assure that they had this unusual compliance and that they also had responders, because pre-randomization they put everybody on these drugs and diet for 6 weeks and excluded those who couldn't take it. So while another study might be criticized in taking such an approach, I think the endpoint that they were measuring, an effect on angiogram, which could be blinded from the investigators, it was permissible in this study, but I think explains this very unusual compliance.
Dr. Roberts, at what point in the evolution of an atheroma is it no longer reversible? Or are all these lesions at least partially reversible? As long as they have lipid in them in some part of them, are they reversible to some extent?
I think lesions which contain a lot of calcium are not reversible. Lesions which contain dense connective tissue, dense fibrous tissue, are non-reversible. There are some lesions, however, that can contain relatively loose connective tissue. And possibly it's not that those lesions are completely reversible, but the fibrous tissue can be more densely packed, maybe toward the side, so the lumen itself actually opens up. But I think it is important, as Dr. Ryan mentioned earlier, the fibrin and the clot component during the acute events, like acute myocardial infarction, maybe unstable angina, those are reversible, and those may be completely reversible. Clearly the lipid is reversible, and maybe the loose connective tissue is essentially reversible.
Dr. Ryan, a practical question now when you're trying to convince patients to go on diets or take certain medications. You want all the ammunition you can present to them, but still be truthful about it, that they should do what you tell them to do. Now, it's possible that the class study is going to be one thing you can quote, that there's some evidence that atherosclerosis, it could be reversed in one of your patients. Now, the paper states at its onset that the purpose was to determine whether aggressive lipid lowering could retard or reverse atherosclerosis. And the study seemed to show that, at least to some extent. But the report concludes only that patients with coronary bypass grafts should be treated aggressively. Are they being overly cautious in their conclusion, and would you be similarly cautious in the advice to your patients? Is it reasonable to infer from this study that all patients should be treated aggressively to lower their lipids and therefore retard or reverse atherosclerosis?
In the real world, I think it's difficult to get this aggressive. The diet restrictions are hard to comply with long term, but as Dr. Gatto pointed out, it's the high dosage of these medicines that have unpleasant side effects. And indeed, a significant number of the population had bothersome side effects. Over time, they adjusted to the flushing and to some of the gastrointestinal discomfort, but a lot of them had drug rashes and one or two of them, some serious eye problems. That's always got to be kept in mind. I think that I noted too that they addressed their present recommendation is for patients undergoing bypass surgery. Here we have a vessel that is disease-free when it's put in place, and we also have very compelling data that shows those vessels undergo change over a shorter period of time as a decade. Now, there may be many factors responsible for that, but certainly the lipid level is a factor, and it seems to be a easier identified target population that may have prompted this.
Now, these investigators chose one treatment regimen that achieved a certain degree of cholesterol lowering. Let's say now we choose another treatment regimen, perhaps with one of the newer, more effective drugs that we'll have soon, plus a diet. And let's say we achieve a 30 or 40% reduction in the total plasma cholesterol. Do we have any reason to expect that we're going to have a proportional, even greater reduction in the degree of atherosclerosis in the coronary arteries? Is that a reasonable expectation?
Well, I think it's reasonable, but I don't think that you necessarily can conclude that because one particular regimen causes a reduction of atherosclerosis, that another regimen that might use an entirely different mechanism to achieve the same level of cholesterol would do so. For example, there are some drugs which lower total cholesterol but lower both LDL and HDL. In general, the total cholesterol is a surrogate measurement for LDL, but there are some drugs which lower both of them. The regimen used in this study happened to raise HDL as it lowered LDL. Nicotinic acid lowers LDL, but also substantially raises HDL. Cholesterol causes a slight increase in HDL. In both the type 2 NIH trial with cholestyramine and the Leiden or Zinnius study with diet, in both cases there was a lack of progression of atherosclerosis observed, but the factor that correlated most closely with lack of progression was the ratio of LDL or total cholesterol to HDL. So I think you have to look at the HDL. You can't just look at the total cholesterol and assume that any regimen is going to have the same end result based on the total cholesterol level.
I think that it's a real milestone that that we are now thinking in terms of actually reducing atherosclerosis medically with diet plus medications. It just seems as though it was a few years ago where we really didn't think in those terms except in certain anecdotal instances that were noted. It's true that, as you pointed out, Dr. Ryan, that this study doesn't prove that it's possible, but certainly there's enough evidence now that this should be a realistic goal. Is that correct?
Well, I think very clearly. I mean, I think the angiogram, while it's just measuring vascular diameter, is still the best in vivo marker we have for coronary artery disease or vascular disease in general.
What we need to know is the critical cholesterol or LDL concentration for producing regression of atherosclerosis given a certain set of conditions, taking into account patient and individual variability. For example, if we knew that in the average patient with coronary disease that if you got the cholesterol down to 140 and maintained it at that level for 5 years, you would have X% likelihood of regression. We might be advocating use of diet and drugs for a patient with a cholesterol of 200. We don't have that evidence today, but with the introduction of new drugs such as the HMG-CoA reductase inhibitors, it may be possible for us to determine in the next 5 to 10 years what is a crucial level of cholesterol and LDL we need to produce that type of regression.
Is it going to be targeted at even the subfractions, the APO, A fractions and so forth, that can be maybe engineered and be more precisely targeted?
Well, that's a very good point because many of the people who have coronary disease have low levels of cholesterol and their LDLs are not very high. If they also have low levels of HDL, that is the most common finding in patients with coronary disease. So we may be looking at multiple approaches, how to get the LDL and total cholesterol down and how to get the HDL up.
Final question, Dr. Ryan, for our clinicians watching the program. Their patient says they know they have coronary disease and they ask the question, okay, doctor, if I follow this diet, these drugs you're prescribing, am I going to get rid of some of this atherosclerosis? What should they tell them today?
I think they ought to be quite open and say the evidence that we are able to really reverse this process. I think many people want to hear that we have that magic bullet that's going to work like Drano, and I think we have to be very clear that we don't have that. We're not at that stage yet. On the horizon are these very promising things that are presented as in this class study. I think we can motivate patients to adhere to a reduction in cholesterol and fat in their diet, and in the symptomatic patient with proven disease, taking medicines that have some unpleasant side effects. I think we can say the data is emerging, but no, we don't have a magic answer, which is what I think a lot of my patients would like to hear me say.
This is the Atherosclerosis Clinical Laboratory of the Methodist Hospital in Houston. Since its opening in 1973, the laboratory has been a world leader in the development and implementation of procedures for measuring plasma cholesterol levels. The laboratory maintains one of the highest levels of reliability in the nation while testing large numbers of samples each day. Such rigorous quality control is reflected by the fact that the laboratory serves as one of these centers for standardization of apolipoprotein measurements for the Centers for Disease Control. Reliability is also the reason why numerous investigators from outside the Methodist Hospital have chosen this laboratory for regular processing of their test samples. In addition to its accomplishments in the clinical setting, the laboratory also plays a major role in research. The Atherosclerosis Clinical Laboratory served as one of the 12 field centers in the recently completed lipid research study and currently is designated as the central lipid laboratory for the 8-year NIH-sponsored Atherosclerosis Risk in Communities investigation. Milestones in Medicine has been sponsored by the Methodist Hospital Foundation, Houston, Texas. For a printed transcript of this Milestones in Medicine program, or for further information on the Milestone series, please send a self-addressed stamped envelope to American Medical Video, P.O. Box 66588, Houston, Texas 77266. To help expedite a reply, please specify program date and topic of the Milestones program.